Hello and welcome back to Creative Minds. Our topic for discussion today will be on glomerulonephritis. But before we dive into the main topic for discussion, I would want us to have a quick review about the functions of the glomerulus. The glomerulus could also be considered as a filtration center of the kidney because fluid from the blood is filtered through the capillary walls of the glomeruli to form filtrate. Now this filtrate that is formed will then have to pass through the length of the nephron tubule, which is a part of the kidney, to form urine. With that said, I would want us to consider the kidneys. The kidneys are paired retroperitoneal structures and are normally located between the transverse processes of T12 to L3 vertebrae, with the left kidney somewhat typically more superior than the right. The upper lobes are normally oriented more medially and posteriorly than the lower lobes. The kidneys are bean-shaped structures and they weigh about 150 grams in males and about 135 grams in females. They are typically about a length of 10 to 12 centimeters with a 5 to 7 cm in width and 2 to 3 cm in thickness. The kidneys have quite a number of functions. However, I would want us to consider just a few. The first is the stimulation of red blood cell production. The kidneys are known to produce erythropoietin, which prompts red bone marrow to make red blood cells. The second is their filtration and excretion of metabolic waste products, i.e. urea and ammonium. The third is that they serve to regulate blood pressure via the renin-angiotensin-aldosterone system. In the cases of hypoperfusion, controlling reabsorption of water and maintaining intravascular volume. Still on the kidneys, I would want us to consider the nephron, which is known as the basic functional unit for urine production, which is also basically referred to as the structural and functional unit of the kidney. The nephron is made up of two parts, the renal capsule and the renal tubule. Now, the renal capsule is made up of a set of capillaries, known as the glomerulus, which is found within a structure known as the Bowman's capsule. The renal tubules, on the other hand, is made up of three segments. The first part being the proximal tubule, which we can divide into two, the pars convoluta and the pars recta. From the proximal tubule, looking at the loop of Henle, which is the intermediate part of the tubule. It can also be divided into the ascending and descending loops of Henle. And then the third part of the renal tubules, you are looking at the distal convoluted tubules, which can also be subsequently divided into the pars recta and the pars convoluta. Now, the distal convoluted tubule subsequently joins the collecting duct. The glomerulus is a network of blood vessels or capillaries, and it is referred to as a theft. It is the first structure you see with the nephron of a kidney. The glomerulus receives its blood supply from an efferent arteriole, and its content, or the content of the glomerulus after reabsorption, is drained by the efferent arteriole. The glomeruli, together with the structure that surrounds it, that is what we refer to as the Bowman's capsule, is considered to be the basic filtration unit of the kidney. The rate at which blood is filtered through all of the glomeruli, and thus the overall function of the kidney, is what is referred to as the glomerular filtration rate. Let's talk briefly about the glomerular filtration. The volume of liquid that is filtered per unit time in the glomeruli is what is expressed as the glomerular filtration rate. The physiological value, or the value for a healthy person, is 120 mL per day, which can also be expressed as 180 liters per day. Majority of this filtrate, roughly 99%, gets reabsorbed back into circulation, leaving just a few liters to go through the process of urine formation. Movement of fluid through the filtration membrane of the glomeruli is controlled and determined by the ratio of the hydrostatic pressure of the capillaries and the oncotic pressure of the plasma proteins. These forces are referred to as the Starling's forces. However, there are a few exceptions or differences from the general principles of the Starling forces. 1. Fluid is not exchanged between the capillaries and the interstitium. but rather fluid exchange is between the capillary and the fluid of the Bowman's capsule. 2. Hydrostatic pressure in the capillaries is different. The movement is only in a one-sided direction, that is, in the direction of the filtration. And then the third exception, the filtration barrier has a unique structure and properties which do not allow passage of protein into the filtrate or the urine that will be formed. Now, this is to say that the glomerular filtration rate is dependent on renal blood flow, the filtration pressure, and the plasma oncotic pressure, and the size of the filtration area. Having spoken about glomerular filtration, let's look at its determinant, or what controls the filtration. Now, the main determinant is the renal blood flow that is directly proportional to the pressure between the renal artery and the renal veins, and is inversely proportional to the peripheral distance of the afferent and efferent arteriole and that of the interlobular artery. Now that we've familiarized ourselves with the glomeruli and then the nephron structure, let's look at what glomerulonephritis is. Itis means inflammation. So glomerulonephritis simply means inflammation of the glomeruli, which are structures in your kidneys that are made up of tiny blood vessels. Now these knots or vessels help filter blood and remove excess fluid. Causes or etiologies of glomerulonephritis. Quite a number of conditions lead to glomerulonephritis, some of which are unknown, that is idiopathic, or some of which are familiar, that is runs in the family. But for the purpose of this very discussion, the causes have been classified or grouped under infectious causes, where we have bacterial or viral origin, autoimmune diseases causing GN, and vasculitic causes of GN. Under the infectious causes, under the bacterial causes, we have post-streptococcal glomerulonephritis. Now, glomerulonephritis may develop a week or two after recovery from a strep throat infection, or sometimes, but rarely, after a skin infection, such as impetigo. In order to fight the infection, your body produces antibodies that eventually settle in the glomeruli, causing inflammation. This type of glomerulonephritis is normally common in children. However, it can also occur in adults. The rate at which children recover is usually higher than that of the adults. Pathophysiology. In glomerulonephritis, there's a reduction in nephron mass as a result of the initial injury to the glomeruli, and this leads to a reduction in glomerular filtration rate. This reduction in GFR leads to hypertrophy and hyperfiltration of the remaining nephron mass, and this leads to the initiation of intraglomerular hypertension. The changes that occur in order to increase the GFR of the remaining nephrons, that is more of maintaining homeostasis. However, these changes could be of harm to the glomeruli as it leads to sclerosis and further loss of the nephron. In early renal disease, a reduction in GFR leads to only slight increase in the serum creatinine levels. However, a condition such as azotemia, that is an increase in the blood urea nitrogen and serum creatinine levels, is significant or apparent when the glomerular filtration rate is decreased to lesser than 60 to 70 mL per minute. In addition to the rise in BUN and creatinine levels, a substantial reduction in glomerular filtration rate results in the following. 1. In decreased production of erythropoietin, hence leading to anemia. 2. A decreased production of vitamin D, resulting in hypokalemia, secondary hyperparathyroidism, and renal osteodystrophy. Thirdly, it leads to a reduction in acid, potassium, salt, and water excretion, resulting in acidosis. And then lastly, it leads to platelet dysfunction, which leads to increased bleeding tendencies. General presentations of glomerulonephritis. The hallmark of glomerulonephritis is inflammation within the glomeruli that typically presents as proteinuria or hematuria, that is nephrotic and nephritic syndromes. Renal function may be normal or it may be decreased depending on the severity and the consistency of the injury to the glomeruli. Some patients present with normal physical examination and blood pressure. Some often have a combination of oliguria, hypertension, and edema. Some types of GN, however, is associated with vasculitic rash, arthritis, or even pulmonary hemorrhage. The hematuria might be microscopic or macroscopic, that is under the microscope or viewed with a physical eye. Microscopic examination of urinary segment is characterized by dysmorphic red blood cells and often red blood cell cast. Dysmorphic red blood cells can be detected with a routine microscopy, but the best option is with the use of a phase contrast microscopy. Usually greater than 30% of RBCs exhibiting dysmorphic features such as donut shape and blebs are highly sensitive indicators of disease within the glomeruli or glomerular disease. The degree of proteinuria varies from a normal range to a nephrotic range, which is greater than 3.5 grams for a duration of 24 hours. A random urine protein to creatinine ratio provides information as acceptable as that of a timed collection, with the normal being less than 0.2 or being lesser than 3.5 grams per 24-hour duration, and the nephrotic range, which is greater than 3.5 grams for 24-hour duration. But then in cases of post-streptococcal acute glomerulonephritis, there's normal or transient or a transiently decreased renal function. Presenting signs and symptoms of glomerulonephritis, usually the acronym should be FAHO, which is hematuria, microscopic, which is visible or under the microscope, like we said earlier on, dysmorphic red blood cells and RBC casts, proteinuria, hypertension, edema, and renal insufficiency, who could be transient or progressive. Investigations include 1. Urinalysis, where we check for RBC casts, LBCs, WBCs, and high protein levels in urine. Serum and urea creatinine analysis, as well as blood and urea nitrogen levels. Renal function test, where we check for or which exhibit decreased glomerular filtration rate. CBC with increased WBC levels, denoting an infection. Liver function test. Normally, hepatitis associated with glomerulonephritis shows elevated aspirate aminotransferase levels. Also, rheumatoid factor results are positive in patients with GN, which is associated with endocarditis. renal biopsy, where a special needle is used to extract piece or part of the kidney for examination, usually microscopic, to determine the cause of the inflammation. Serology test, which helps in diagnosis of rapidly progressive glomerulonephritis, measures anti-neutrophil cytoplasmic antibody and anti-glomerular basement membrane antibodies. Then we have your imaging tests, such as the kidney X-ray, ultrasound, and CT, that allows visualization of your kidneys. Complications include acute kidney failure, hyperkalemia, pericarditis, nephrotic syndrome with a greater than 3.5 grams per 24 hours of protein in urine, pulmonary edema, uremic encephalopathy, high blood pressure, just to mention a few. Principles of therapy. Current treatment of GN has two objectives: to control inflammation and then to inhibit fibrosis. Anti-inflammatory agents include intravenous or oral corticosteroids, cyclophosphamide, azatropine, and fish oil supplements containing omega-3 fatty acids. Drugs that reduce proteinuria may inhibit injury and fibrosis to the tubules, and these drugs may include ACE inhibitors, ARBs, and statins and antioxidants. Loop diuretics, such as furosemide, may be used in patients with edema and hypertension. This is to remove excess fluid and then correct the hypertension. Vasodilators such as nifedipine, hydralazine, diazoxide may be used in severe hypertension or encephalopathy. Diet and activity. Sodium and fluid restrictions is advised for the treatment or prevention of signs and symptoms of fluid retention, such as edema and pulmonary edema. Protein restrictions are necessary in patients with azotemia if there's no evidence of malnutrition. Also, decrease intake of foods such as coconut and banana, since they contain potassium, to help prevent hyperkalemia. Differential diagnoses include IgA nephropathy, rhabdomyolysis, sarcoidosis, renal cortical necrosis, hepatorenal syndrome, polycystic kidney disease, pyelonephritis, membranoproliferative glomerulonephritis, Wilms tumor, systemic lupus erythematosus, just to mention a few.